Good evening, good early evening, everyone, and welcome to our first Mindworks chat. We're recording tonight's conversation, and it'll be posted on our Narrative Mindworks community blog. So we're really thrilled to have all of you here. I'm Tony Ericetti, Director of Programming here at Narrative Mindworks, and I'll be the discussion facilitator. Derek McCracken is also here minding the chat.
Hello, everyone. Welcome.
We'd love to hear from you, but feel free to post a comment or question in the chat. But we really do encourage a conversation. But feel free to post to that chat. So today's question, I think, is both deeply relevant and some even might say debatable. Can empathy be taught? And so to kick off our discussion, we're really fortunate to have two esteemed panelists with us, Andre Lijoy and Elizabeth Tracey. Andre is a family medicine physician and narrative medicine CPA 2019 graduate, and one with whom I've had the honor and pleasure of co-facilitating with him during narrative medicine workshops through Columbia's live virtual sessions. Elizabeth is from Johns Hopkins. She's a chaplain, medical journalist, podcaster, and innovator who created, quote, "This is My Story," or TIMS, which connects patients, families, and caregivers through short recorded interviews. And if you want to hear more about their work, go to our community blog and you'll find some information about them. And they're going to share their thoughts, insights, experiences, and perspectives on this thought-provoking topic, starting with their thoughts on the article, "Empathy Can Be Taught and Patients Do It Best." And after hearing from Andre and Elizabeth, I'll open the floor to all of you for your questions, comments, and your own reflections. But here are a couple guidelines to start. Please mute your mic when you're not speaking and use the raised hand function if you have a question or comment, and I'll call on you. To raise your hand, you want to go to the reactions tab at the bottom of the screen and then click on the raised hand icon, and I'll then be able to recognize you. So let's dive into the conversation. And again, welcome Andre and Elizabeth. And the article, it makes a claim right in the title that empathy can be taught and patients do it best. Really wondering about what your initial thoughts on the article are, and did the article's perspective align or different from your own views? What do you think?
Andre, do you want to go first?
I'm going to weigh in with a quote from William Osler, the father of modern medical education, who said, "It's a safe rule to have no teaching without a patient for a text, and the best teaching is that taught by the patient, him or herself," which is one that I've had up on my office door for residents and students to read. So in terms of empathy, can empathy be taught? I am a firm believer that we can do that. However, it really takes deliberate study to cultivate that skill. So there's a long way between that quote unquote teaching and the integration and ability to execute good empathy. In terms of patients teaching us, again, absolutely. And I think this article gives a dramatic example of that. But the question remains, patients aren't trained as teachers. So I think it's incumbent on us, the clinicians, to learn how to harness that teaching and bring it into our armamentarium. I'll give it to Elizabeth. See what you think.
Well, in full disclosure, I have to say that with my other hat, which is the medical journalism hat, I do a weekly podcast that's a roundup of the medical headlines, and it's called PodMed or Double T Health Watch, actually, and it's from Texas Tech. So we actually recorded this morning, and I was telling Rick, who's the dean and the president of Texas Tech University Health Sciences Center, about this afternoon and where this article had come from. So we had a little bit of a talk about this. So I had a little bit of rehearsal, in fact. before ever coming to this. I think a lot of the sentiments that the author invokes are sort of like apple pie and motherhood and baseball, right? So he says this thing about his attending playbook: acknowledge, validate, ask open-ended questions, and engage in shared decision-making. And so that seems like one of those things that is just really like, how could we possibly argue with that? I think a little bit further on in the text, though, he says something that I don't really agree with. He says, unlike personality traits, empathy is a cognitive skill that can be invoked, taught, reawakened, and nurtured. And I would respectfully submit that we've all seen like 2-year-olds on the playground, and one of them falls down and crashes into something, and all the rest of them come running over and say, "Oh, are you okay?" Well, that's something that is manifest in 2-year-old behavior that clearly is not cognitive, it's innate. And so I really believe that empathy is innate for most of us. And I think, and I'm going to call that like those of us who could be called neurotypical. And I would also say that at my fine institution, and I've shared this story already with Tony, the TIMS files, the This Is My Story, the audio files, are typically used at rounds. And at Hopkins, I say we have a very high density of people who are on the autism spectrum. And sure enough, we were using a TIMS file on rounds, and we were all standing there. So all the attendees and the trainees and everybody else, we played the file, and somebody standing right next to me who had an MD, PhD turned to me and said, "What do you want me to do with that?" And it was just so abundantly clear that that content just went straight over his head. It just was not something that resonated for him. It wasn't a place where he was ever really going to be able to feel what I was hoping to evoke in creating those things. So what do you think about that, Andre?
So I operate from the perspective that there's a lot written about the neurobiology of wisdom, compassion, caring, and so that I think that people have different endowments. But I also operate from the perspective that in medicine, we attract caring people, that they've got some pathways firing up there that encourages them to care. And for me as a teacher is recognizing where my learners are on that spectrum and see, can I get them from the varsity team up into D2 college level, or can I get them out of the middle school team to play varsity? And can I move them up? I think there's a very small proportion of people who don't have those pathways operant, and you really can't improve them. I call them some, and this may not be fair, chairman problems. But I think it's a very small group, and the ones who come to certainly to primary care, talking to them and reading their personal statements, they certainly have an inclination to care, and so that's my construct in working with them.
Yeah, I would absolutely agree with you. I think the folks who tend to gravitate toward any primary care specialty, and I would also include in there most of the cardiologists I know, most of the oncologists I know, I would say are people who have a pretty substantial reservoir of empathy that they employ in their practice. And certainly there are other specialties, and I'm largely in the ICUs, and so that's a different skill set. I mean, I really call that battlefield medicine. And I think that what you bring to that is a little bit different. And there may be very well a carapace that prevents too much resonance with what's going on, because it can be so incredibly emotionally draining.
I think that is such a great point, that if if we follow some of the generic definitions of empathy as walking in someone's shoes, walking in a patient's shoes, you'd probably be disabled by lunchtime. You wouldn't be able to manage that. So how do you maintain the caring in the face of the difficulty of this work, and also the increased workload that is sometimes required of physicians in practice? How do you keep that empathic spirit alive when the business model kind of contradicts that, or makes it more difficult for you to actually pay attention, ask questions?
So I
I
think first of all, you have to be you have to be skilled
Mhm.
and your tools of listening and watching, because those help us be more efficient. And I will argue that narrative medicine doesn't slow me down. It makes me more efficient. And to cut to the quick, what it does is it keeps me from barking up trees that the patient's not going to go up with me. Okay, so it saves me time. It makes me more efficient. But you have to be competent at those skills, and you have to be competent at broadcasting your care and your concern. And I think that's very important. And you can learn these things. They can be learned. And there's simple ways to teach the residents how to do that. It's not intuitive for most of them because, what's important to them is they don't want to look dumb in front of the patients. So they want to know which test to order, which prescription to prescribe, and which button to click on the computer. So they did, as we go about digitizing our patients in the course of the day. So I think those skills, those fundamental skills, are very important.
Yeah,
So-
and they're, yeah, please, go ahead.
Oh, I was going to say, so Andre, I'd really like you to step into that space of exactly how you do teach residents or anyone else how to convey the fact that they feel empathy for a patient. So
I start with very simple rubrics. And believe me, I think of this as a very complex and high level skill. This is not soft. And the only time I've refused to do a narrative medicine session is when someone asked me to come and talk to their group about the soft skills. And I said, I won't do that, but I'll come talk about the hard skills. I start with very simple things. So start to develop some simple scripts. You know that there's a woman who's coming in with a child with otitis media that's been up crying all night. Well, when you walk in the room and introduce yourself, the first thing out of your mouth is, well, you must be exhausted. Must be exhausted from being up with a sick child all night that you're worried about. And to start to develop some of those simple, and then see what happens. And then see what happens. How does that parent respond to you? So I start with very simple rubrics like that, and then I tell them now you've got to be able to translate it from here to here. So it can't just be a script for it to work well. It's got to be heartfelt, and it takes deliberate practice. So anything you get good at in anything is deliberate practice, right? The Beatles didn't become great by just hanging out in the basement and playing their instruments. They were deliberate about their practice, and everybody's like,
yeah, so I'd like to just follow that a little bit further and ask you if you believe, because it says in this paper, and again, this was part of this robust discussion we had this morning, so I have some ideas about this already. It says, instead, the best judge of empathy is the patient receiving the care. So one question I have is, in that clinical encounter, if you reflect things like it can be somewhat formulaic, right? That you would reflect what the patient, you first of all ask an open-ended question, show that you already understand some of the circumstances that are surrounding the patient. For example, the example that you just gave about the mom, and you know that she's been up all night and this has got to be really terrible. So starting with that, leaving it open, allowing the time for her to reflect. So to some degree, those things can be fairly formulaic, and instructing somebody to ask specifically about those kinds of things. Is there a difference between empathy and between the patient's perception that they're being seen as a person?
well, absolutely. And I think in that this clinical vignette that is described, it's really an amazing story. And what a lucky team to have a patient that's willing to share what she shared with them, and telling them that, I'm not being seen, I'm not being heard, and a gutsy intern, a gutsy intern. But I think there's definitely a difference in that, and that's where we have to cultivate a barometer that's just out there, and the radar that's out there searching for these things as we work with patients. And it shifts from being cognitive. It's just from being cognitive to, almost coming from your gut. It's intuitive. It becomes intuitive, part of your fiber as a clinician.
So do you agree with the assertion that that empathy is an inherent skill that somehow gets damped down in the process of medical education and then needs to be resurrected and nurtured again so that it can be employed in the clinical encounter?
So that's a good point. She talks about, the author talks about curiosity and passion and questioning. And what I observe is that within 3 months, interns are no longer curious and they're no longer asking those questions. What they're focusing is on process and get the job done and clicking through the computer. And the data is that on the inpatient service, on a medicine service, a resident will spend 7 minutes with the patient and 28 minutes in the computer. So their focus is not the patient, it's to get to the computer, because that's their interference with the end of the day. So I think the other thing is, if we have adopted a competency-based educational model, okay, so it takes 5 to 10 years to master. Okay, we have medical students in school for 4 years, residents for minimum of 3 years. When they leave, they should be masters of many, many things, especially professionalism, and empathy falls into professionalism. So what are we doing in medical school and residencies to cultivate deliberately good empathic skills? And I would argue, I would like my residents to have good compassion skills, even more than empathy skills, which is another discussion, and we might get into that more. Because the compassion piece, and again, I think narrative medicine calls us to that. It's receive the story, embrace the story, and know what to do with it, act on it. And compassion is an act. It's an action. It's not just a passivity.
Unless you can convey that compassion that you're talking about, the curiosity could really seem more like an interrogation. So it really does require perhaps sympathy for the patient first, which often passes as empathy, in particular in performance assessment, which has been my field for 30 years. So, but you need to open the door to the patient by acknowledging their pain, doing something to connect, and that's a very individual act, and then be curious about them. And
genuine curiosity, and that curiosity is going to lead me to a way to help you.
Yes, that's right. And save time. I was having a conversation with Temple West, who's here, and she brought up that point as well, that it can save time, as you're talking about. You know quickly, or more quickly perhaps, where to focus, where not to focus, if you have this empathic approach to really being curious about what's important to the patient. But I have a question from a patient point of view. There's been a lot written on what patients want from their physicians, and maybe this is part of the whole culture. I read an article years ago called "The Charm of Medicine," and the idea that, if patients don't receive medication at the end of the encounter, they have not been treated. Some patients don't want empathy; they want treatment. I am one of those, by the way. I don't necessarily want to be understood. I want to go in and have a problem solved. I don't want to tell my story necessarily. I'll find a psychotherapist. So, and maybe it's the way that I've been trained to think about medicine, that this is not the place necessarily to disclose. And I do some lying here and there. I don't tell everything. That's also common with patients. They don't tell the truth, I think, as you probably know. So I'm wondering about that. Do you find that patients really don't want to be understood? They just want to be given a treatment, a pill, something that they can go away with without the conversation? Is that also a limiting factor in this conversation?
Elizabeth, you want to comment?
Yeah, so it's just interesting to me to reflect on this, because I was at another webinar recently where somebody asked me, why did I like being in the MICU? So I'm largely in the medical intensive care unit at Johns Hopkins Hospital. And of course, when we take a look at death, for example, that's where of the 1,000 deaths that take place at JHH every year, 700 take place in the MICU. So what it is I love about it, though, is that there is no time for any BS. Everybody is really quite focused on things that are important to them. And so when the patients, there just isn't a carapace. And Tony, I'm going to suggest that your carapace is fully intact even as we sit here. And that perhaps if you were in a situation where you were critically ill, that would be completely irrelevant. And what would be coming forward would be those things that are really resonant for you about who you are and what you want. And particularly when you have the mortality call sounding and you're examining those kinds of issues. And so that's my exposure with it. So it's rare for me when I record with a patient, almost to a person, they say to me, wow, this is amazing. Nobody has ever asked me these kinds of questions before. And they seize it as an opportunity to really encapsulate these things that, yes, this is important to me. This is what brings me joy. This is what brings me peace, and so forth. But that's my environment. And so I think it's a very different situation than many others.
Yeah, is it the method by which you ask for the story? It's really novel. Tell me a story and do it in 2 minutes. Answer these 4 questions. That's not usually how medicine works, but it does in this situation with Tim's. It really does unlock amazing little vignettes, little thumbnail sketches of patients' lives. I've just been amazed by what I've read from the audio. The audios that you've created. I have a question for the both of you. Then I'd like to turn it on to the audience, or turn to the audience and get their ideas. So this is a question for both of you. The article says that one teaches best by role modeling. And so I can think of at least 2 ways of role modeling. One is observational, where you watch someone be empathic with a patient and then model their behavior, and then you model your own behavior on their behavior. Then the other one is that I can think about, and I could probably think of a few others, is when one is the object of empathy. That is, for example, when a clinical supervisor or preceptor is genuinely curious about the trainees, the learners' thought processes, and really wants to know, that was a really interesting thing that you did with that patient. Tell me more. What do you think? Do you have any thoughts about role modeling as a way of teaching? Do you have your own way of role modeling? Does that make sense?
The learners watch us. And before I go on with that, I want to say one thing about your previous question. The earnestness in which we conduct our work, because residents want us to be competent with our medicine, with our science, okay? So with the earnestness in which we conduct that interview, and we examine that patient, and we explain things to that patient, broadcast caring. We care about our job, and if we care about our job, we're obviously caring about them. So then you can bring other layers of empathy in, depending on what I read in the story. And if I saw you, I would read the story that, what he wants me is to do is take care of his issue today and be earnest about that. Yeah. So I'm sorry, ask the other question again, Tony, quickly.
No, it was about role modeling. And you said
okay,
that,
yeah. So they watch us. They watch us. All right. Mm-hmm. And they watch how we treat patients, and they watch how we treat them.
Them, right.
And I think one of the most important roles for me as a teacher is I have high expectations for them, because they have to be competent. It's not just me. It's just everybody inside. But my job is to show them the way. Okay. So that if they always feel like they're constantly judged, any sense of ridiculing them in front of others just shuts that down. Okay. So part of that job is, the important part is showing them the way to the high expectations. And you do it. And again, the competency-based model lets me break it down into bits for them, which helps them. And then also for the high level, I mean, they're all advanced learners. They got through medical school. Okay, there's no question. But the ones who are really performing at higher levels, it challenges me to help them. It's much more difficult to help them. But on the other hand, being empathic towards them and their colleagues makes a big difference in how they will go out and supervise them tonight when they're covering the hospital or whatever service.
Yeah, that's what I believe, that you really have to experience empathy from your supervisors, your preceptors to really get it. And if you had,
They really watch us. They watch us.
yeah, and feel that. Elizabeth, do you have any thoughts about role modeling in this regard?
Yeah, so I mean, I certainly see in the clinicians, I see lots and lots of clinicians and interactions with their patients. And I would agree, the ones that, of course, resonate really very much for me are the ones where there is an enormous amount of empathy and caring that's demonstrated by the clinician, in addition to all of the knowledge base and the didactic skills and all that they bring to the table. And I would agree that the learners do that too. I would also agree with you, Andre, that there's a point at which the empathy seems to really go away. And I've had the blessing to really work with a lot of medical students who are quite interested in this TIMS initiative and have volunteered and gone on the units and all that. And they absolutely have it. And they are very interested in that aspect of medical care. And so I guess then the question is there a way that we can inoculate them against that precipitous loss of empathy that seems to be a given when it comes to their training?
Well, I will tell you that after narrative medicine sessions, interns come up to me and say, I finally feel human again.
Yeah. Yeah, and Elizabeth, your Tim's files have really shown me that to listen to a patient's story, it doesn't take long, a couple minutes, and it opens up other areas of exploration. I think in narrative medicine, you think, we have to pay attention to the patient's story, and we think of a long story, something that will take a long time to grasp. But sometimes it's you'll hear a sentence and there's a story in that that requires you to really follow up. So a story can be very short. It doesn't have to be long, and so therefore it's important that clinicians know that, I think. And I think, how are we doing?
I want to say
Derek?
one thing about
Yeah,
role
please.
modeling. So there's
Yeah.
risk for us. There's risk for us in role modeling, and that we can look really bad in front of a learner if it doesn't go well,
Yeah.
right? But again, how we handle that is a great example for them, right? Because they're going to have times where it doesn't look well, and we talk a lot about safe space, but the world of medicine, the realm of medicine, is not a safe space. And care as we care for patients. And really, when it comes to empathy, empathy is you got to try something. So it's trial and error, and it's reflection, and it's revision, and being humble. But it can really happen to us that we look really bad in front of our learners, but it's such an important lesson to debrief with them and reflect back on our own experience. And I think it's really valuable. It gives them courage.
Have you ever had empathy for your supervisors, the ones who are less than perfect? They're not the role
Yeah,
models. Yeah.
it started out with having to deal with me as a learner. And
Yeah. Well, yeah, being humble means you're going to make some mistakes, even as a
I
supervisor.
I had very good mentors. I have to say, I've been very privileged.
Yeah. But that's a whole other topic, how to get a good mentor. It's so important. Derek, how are we doing with chat? Are people
Yeah, we're time check is about 5:30, and Doris had asked if they can address the skill of listening specifically. And then Lauren had asked, should a type of formalized narrative practice of scale be developed to augment rote process skills development with close listening design matrix skills? So those are two things. And then I think that'll get us started.
Elizabeth, you want to start off on that?
You can start off on it if you'd like to, Andre. It's fine with me.
Well, so I think listening, um, I have a methodology that makes it easier. Number one, the first thing I ask the patient is what's important for you today, and then I wait. If you want to see a doctor squirm, you just be silent and be silent for 30 seconds. But I ask what's most important, and sometimes they need a little explanation, but usually they don't. I may have to say, well, what's most important for us to take care of today? And then the other really helpful question is, what do you worry about the most? What worries you the most? And I listen, and I let them tell me their story in response to those questions. They really have revolutionized what I do and the information I get from patients. It's made a complete turnaround since I do that. And again, it makes me more efficient because if I start going into my long list of agenda um, uh, and don't recognize that's not important to them, then I'm wasting time. On the other hand, sometimes my agenda is really important, and so that I can really redirect people then and say, I know that's important for you today, and we'll deal with that. But there's something really important here we're going to discuss. So I think just and then knowing how to ask the good question that extends the conversation a little bit, and so it's developing that curious, and it's really usually a curious question. Help me understand this better. And so that's how I would start. Elizabeth, what are your thoughts?
Yeah, so blessedly for me, the great thing about being in the chaplain role is that what we have, our lingua franca, is time. And so being able to walk into a patient's room and sit down, right? Hi, I'm Elizabeth. I'm a chaplain on the unit. And I'm just going to sit here until you talk to me and tell me what's important to you. And really, that's a huge luxury. And I think it's one of the only places in my world where I really surrender time the way that I can and do in that situation. So I think that your point about asking these questions and then just waiting until somebody steps into that space. And then a lot of times, especially when I'm recording the Tim's files, I will have to ask prompting questions. So someone will say something like, what brings me joy? My family. Yeah. So tell me about your family, and so, right. So get them to sort of embroider on this initial statement that they've made. As Tony would say, or has said, in every single, none of the recordings, and I've done literally thousands of them now, are ever the same. So people, when they're asked those kinds of questions and they have somebody who's just kind of patiently waiting for the answer, also give themselves a moment to really consider, well, what might my answers to this be? And then to actually provide the answers. So I think that the nature of patience is also, that's absolutely spot on. You got to be patient and wait for somebody to step in.
The other thing that I think is really important to us, even though I'm retired from my practice, I do some urgent care work, and I don't turn the computer on until I have to. And the computer's up here on a higher desk, and I pull the stool up, sit in front of the patient, and tell me what's going on today. What brings you here? What's important? That's what I. But I don't turn that computer on until I have to. And that in this day and age, that's a powerful message of I'm listening to you.
In the interest of time, we only have about 10 more minutes, so I really want to hear from the audience. Derek, anything that you want to mention? And a couple people have raised their hand. David Simons has raised their hand. So,
yeah, there was Lauren's question about should there be a type of formalized narrative practices scale developed, and then Julie asked about empathy, since it's both innate and hard. She feels like people might think it's important. If you're just born with it, then how hard, important can it be? So one's kind of around ethics, the other is around metrics.
Do you mind, Andre, if I just step into this space just about the empathy? It's hard. I would just say that in the papers that I've published on TIMS, we definitely discerned that when people listened to the TIMS file, we had a very consistent about 6% of the clinicians say, this actually created more distress for me. And we followed that up in the qualitative interviews and asked some more about that, and largely learned that they felt that when they listened to the patient's voice and the patient identifying what was important and what brought them joy, especially in the context of their prognosis, that it hurt. It was painful to hear that. And it removed a lot of their ability to maintain their professional distance. And to that, whenever I talk to clinicians about that, I always say, well, I'd a good deal rather have you as a whole person as my clinician. And it sounds, Andre, a lot like you are really a whole person in your clinical practice. You bring your heart as well as your head, and you're okay with showing that. And so I would rather have clinicians who are capable of recognizing that, oh gosh, that's a really painful story for me. And then getting support and being able to share that with others and normalizing all of that, because I don't think we normalize that at all in the medical environment. It's like we just keep moving and drop all of those things on the side, and that discourages manifestations of empathy also.
I want to make sure that David gets to ask his question, and in the meantime, also I'm going to put in the chat right now some resources for everyone about empathy, assessing empathy, and some references and so forth. So, David.
Yes, thanks. Thanks very much. I really appreciate this a lot. I've been working with medical residents for 10 years now at the University of Central Florida in the Orlando VA. And I was very much on the side of you can't teach empathy. I mean, some of these young people come and they are just wonderful. And some of them, it's hard to know. And I've been on the, I think I like the word in the paper about that it's reawakened, because I do think that it's innate. But I'm really, this role modeling thing is something to me. I'm just trying to think real practically here. How can I start doing this with my residents and reflecting on the story? I mean, how many times do we have a difficult patient? And I think this writer, it's almost like that. There's some famous saying about if a lesson needs to be taught, a teacher will arise. How do you practice recognizing when there is an opportunity to role model this?
I think they present themselves all the time. If again, we don't. I think direct observation really helps. So, and I think in terms of monitoring progress, I think direct observation is very, very important. I mean, had this teacher not been in the room to witness this, and it was that story just blows my mind. That what that patient said, and there were so many teaching opportunities and points to make there. So I think direct observation is important. I actually am not convinced that the patient is the best quote unquote teacher. I go back to we learn tons from them. There's no question about that. And we should follow Osler's mantra of having the patient for a teacher. But again, we have to pay attention. We have to listen, watch carefully, and also be able to draw them into that. Asking them to give an assessment. I do sometimes have relationships with patients that I can sit down with them afterwards and say, tell me how it went with my student today. And then I can feed that back. But operationalizing that across the board, I think would be very difficult. And then getting observations from other staff members who work in the office. Again, I won't do that with a checklist. I bring the staff in together and I go through the list of competencies we're looking at, and I have to direct them. They're not trained. They're not trained to evaluate. So I have to get a collective voice. So I think doing that is another helpful place. And then hearing from their peers. But again, hearing from their peers, there's been a lot of checklists generated in this realm of competency-based education. But I think seeing the patients with the residents is really the way that it really, really happens. And then we get to practice ourselves and then go reflect ourselves and revise for ourselves.
Yeah, David, I would also refer you to Jenny Rudolph and her colleagues from Harvard Center for Medical Simulation. Are you familiar with their work on debriefing? It really changed my opinion about empathy. They practice something called empathic inquiry. You know, and it's a way to you know, connect with your students, connect with your learners, whoever they are, and really be truly curious about why they did what they did. And then you have to be also willing to change your mind. Sometimes a resident or a student will come up with a good reason for why they did what they did. I was working with a group of students from Asia. I noticed that they were great with the medical part. And I said, well, what is the rule for empathy in your country? And they said, well, the family does empathy, we do medicine. That explained a ton to me about how they thought. So I said, finally, I'm understanding what I'm seeing. So debriefing is really, I think, key to this. So I'll definitely pass some articles on to you or anybody else that might be interested. I have a lot of material on this. It's been something I've presented on and studied.
Thank you, Tony. I would love that. What was her name again?
Jenny Rudolph. Yeah, if you Google her, you'll find titles such as
Thank you.
"Briefing is not is a judgmental debriefing." The idea that you know, as the expert, you want to point out to the learner things that you have questions about. You make a judgment, but then you try to find out what's going on with them. What is your thought process? How did you think through this? I'm really interested. You know, making people the objects of your interest, I think, goes a long way to uncovering their thinking, their methodology, and so forth. Any other questions? Yeah.
The ask, tell, ask model is what I do with the residents, and it puts it in their court first.
Yeah. Any other questions from the audience or anything, Derek, in the chat? I know that looks pretty active.
Yeah.
Yeah, 3 more minutes.
Michelle says, let's see, or Susan says rather, there's a need for people to want to be included today more than ever to make connections and to stay human. The interns today want to understand how to be empathetic and relate to patients on a human level is critical. One issue is where to find the time in a visit to do this.
There's that time. Time to the critical issue. And any other thoughts in the chat that you want to bring up, or any other? Oh, Doris, you have your hand up. Thank you.
So I heard about a BEAM program, which was at Hopkins, where a person, obviously with a laptop, was following people doing rounds. And she showed them a picture of Frida Kahlo, which obviously has lots of stuff, medical stuff coming down. And so everybody reflected on that. And by the end, she asked the group, did anybody notice her tears? And they all said that the next room they went into, they were changed as to how they looked at that patient, just based on that painting and then recognizing they had missed the tears. I found that very, very powerful.
Yeah, it's the power of art to really change our perspective. Yeah.
Yeah, there's 2 formal programs at Hopkins where they do that. There's one that they do with the medical students and where they take them. There's 2 pretty good museums where they take them and they actually use a number of paintings to elicit exactly what you're talking about. And then there's another in neurosciences where they do a similar thing and try to really assess it on a more quantitative basis. So yeah, but thanks for bringing that up.
We've got
There is a-
1 more minute. I'd love to hear from somebody else in the audience before we stop. Anybody else like to raise a question or concern?
Susan is raising her hand.
Yeah.
Susan.
Hi there. How are you? I'm actually listening to this from a patient point of view, but I'm also an educator, lifelong educator. So I've had to model how with students for them to be empathetic to their other students. But one thing that's coming to mind is this human connection is so important. I now have a concierge doctor because she very much wants to take the time to be able to not only research your issues, but to talk to you more. But a lot of people cannot afford that. And you go to a regular doctor and they only have so much time. And there's where sometimes along the way, they may lose that connection to human beings. But I just wanted to add that our Surgeon General has declared loneliness and isolation as an actual national crisis right now. So that I'm glad to hear Elizabeth say that the interns are more interested in this now, and it may very well be a product of the lifetime that we're living in, especially post-pandemic. So the notion to make the connections with real people, I'll just give you one short story about the way I turned it around to a surgeon that I had to go to for a heart surgery, who was very clinical, never smiled. You really do want them to be focused because they're going to open up your chest and operate on your heart. So you don't want them to get too touchy-feely. But on the other hand, that when I was being rolled in, it happened to be on May 4th, and my PCP said to me, well, what a great day to be operated on. She said, may the 4th be with you. So as I was being rolled in, the surgeon turned and I looked at him and he had his mask on. And so I couldn't see his face necessarily, but I said to him, thinking that probably he is a nerd and he is probably someone who loves all this stuff, I said, may the 4th be with you, doctor. And the biggest smile came on his face. And then when I saw him again, he was much softer to me. He was much more understanding. Just that thing you mentioned a minute ago, Doris, about the tear. I do think that the human connection is so vital, and actually teaching patients how to take care of themselves once they go home. You know, I think they truly want to be included in their care. Now, some just don't want. As you said, some people want to go in and just get, you know, give me a pill and I'm going home. You know, so I want you to solve all of my problems. But mostly for all of us, there's something about us being involved in taking care of ourselves every day that's just as important sometimes as going to a doctor. So I like it when doctors actually can help me with, well, you know, this supplement may help, or this one is nonsense, or this is that, because I'm seeking those kinds of solutions myself sometimes. So I just think that the human connection, and that ties in empathy. I might be scattering around a bit, but the whole notion is a lot of people are lost today, and they come to doctors for many things.
Yeah, thank you so much. And in the interest of time, we really have to stop. But Susan, one thing I'd like to just comment on is you made an empathic connection to your doctor as a patient, and there isn't enough talk about patients being empathic with their doctor. That would certainly make things. It would certainly change the dynamic. It is not a one-way street.
Exactly. But see, I have a background in this. So in other words, I
You know
was
how to
ready
do
and
it.
prepared. I watch people carefully and I actually try to relate to them the way I can see that they may want to relate back. And that's where it came from. So not all patients can be like that, but I try.
I think it's really important. So we're at time, and really want to thank everyone for being here today. I'm sorry we didn't get to everyone. Thank you so much, Andre and Elizabeth, for talking with us about your work. And I think we're going to keep talking about this. And Susan is talking about a community. We're a community, so let's keep talking about these issues. Really wonderful. Thank you so much, all of you, for being here.
Thank you.
Tony,
And-
can I just interject one last thing? This is from To Kill a Mockingbird. And Atticus says, you never really understand a person until you consider things from his point of view, until you climb into his skin and walk around in it.
That's right.